All right, Chapter 26, Gastrointestinal Disorders, Part 2. Moving further down the GI tract, we're going to start with biliary disorders. Here we're talking about cholecystitis, cholelithiasis, and choledocholithiasis. So, cholelithiasis. Those are bile. That's where your bile solidifies as gallstones. 80% of those gallstones are formed from cholesterol, so people with higher cholesterol levels may have a tendency to develop these gallstones. And here's a picture of a gallbladder full of gallstones. You can see that they look like little kernels of corn. And again, they're caused by higher cholesterol counts. Acalculous cholecystitis is obstruction of the cystic duct from gallbladder sludge or inflammation. It may cause gallbladder or binary colic, and colic is an intermittent pain that we see not only with gallbladder stones but also with kidney stones. If it persists, the gallbladder becomes inflamed, distended. You get gallbladder wall edema. The edema can lead to ischemia. The ischemia can lead to necrosis and actually death of the gallbladder. If left untreated, then the gallbladder becomes necrotic, gangrenous, and can lead to a bacterial infection. Cholangitis is an infection that spreads to the remainder of the biliary tree following a cholecystitis, and the cholangitis can be life-threatening, and it's extremely rare. In fact, I've never heard of it until I actually looked at the chapter on this particular disorder. Choledocholithiasis, those were stones stuck or formed in the common bile duct, and again, most of them just refer to them as gallstones, and there are people that are at higher risk than others to develop these stones. They're associated with racial and ethnic factors as well as the 5 F's. Those people who are fair complected, heavier set, fertile females in their 40s often have these stones. Choledocholithiasis can be asymptomatic, or if there is symptoms, the pain is usually much like biliary colic or gallstones. It's a constant pain in the epigastric region in the right upper quadrant. It radiates to the right upper back, shoulder, and scapula. And because it's in the right epigastric region, gallstones can mimic, depending on how described by the patient, can mimic heart-related chest discomfort, even though they often say it comes and goes and it burns, and that's typically not heart, but you just can't be too careful in some people. Symptoms of diseases of the gallbladder include nausea, vomiting, and fever, indigestion, belching, bloating, typically following a big heavy meal with lots of fat, which calls for the gallbladder to release bile into the GI tract to help digest that fat. That often triggers a gallbladder attack, which is extremely painful. On physical exam, there may be some right upper quadrant and epigastric tenderness. They could be guarding the right upper quadrant. They may have a positive Murphy sign, and that's where you hook your thumb under the costal margin and have the patient take a deep breath, and if they hurt, it's positive for gallbladder. And then you hook your fingers under the costal margin, have them take a deep breath, and again, if it's painful, then that's positive for gallbladder disease. They may be febrile, and they may be hypotensive or orthotachycardic. Treatment for gallbladder disease, IV fluids, if there's been a lot of vomiting and volume loss. Pain medications if they're in a lot of pain, so morphine, fentanyl, and then antiemetics if like Zofran if they've got a lot of nausea. Pancreatitis is inflammation of the pancreatic gland, and as a result of the inflammation of the pancreatic gland, there's a decrease in peristalsis of pancreatic juice, and pancreatic juice, or the pancreatic enzymes that aid in food digestion, if they're not being excreted, they auto-digest the pancreatic tissue, which leads to inflammation. And it just makes sense that these enzymes that are designed to break things down, like proteins and amino acids and fats, if they're stuck in the pancreas, they start to auto-digest the pancreatic tissue. They also can get bowel wall edema as a result of this. And here is a example of an acute pancreatitis. They've got a pancreas there, and all the black area that you see throughout the pancreas is the autodigestion of the tissue itself. Causes of pancreatitis include alcohol consumption, and it's usually related to binge drinking. And it doesn't have to be chronic binge drinking. An individual could binge drink once, have 6, 8, 10 beers, get really intoxicated, and over the next couple days develop a pancreatitis. It's also related to gallbladder disease, because gallbladder disease, gallstones, plug the gallbladder but can get out of the gallbladder and plug the biliary opening where both the gallbladder and the pancreas share a common duct in order to get their fluids into the GI tract. Findings with pancreatitis: constant severe mid-epigastric pain that radiates directly to the back. The pain may travel to the right or left upper abdominal quadrant. When you do your OPQRST, that's of course a great way to assess for pain. You also want to check for a history of trauma, because trauma can abdominal trauma could lead to bruising or damage of the pancreas, as well as the spleen, which is just below the pancreas on that side. You also want to think about medication ingestion. Certainly an overdose of non-steroidal anti-inflammatories, aspirin, those sort of things can cause pain in the abdomen. And then illness. Do they have pancreatic cancer? Symptoms: fever, nausea, vomiting. They appear systemically ill. They're restless, tachycardic, tachypnic, febrile. Again, we already said they had fever. They're hypotensive. They can be jaundice if the again, common bile duct is obstructed along with the pancreatic duct. May affect liver function as well. Epigastrum, or right upper quadrant, is tender. Breath sounds are diminished or absent, and that just has to do with when a person takes a deep breath and the diaphragm flattens against the stomach pushes against the pancreas, and it causes an increase in pain, so they have a tendency to take more shallow breaths. Their abdomen may be distended or guarding or rigid. They may have an acute abdomen as a result of hemorrhage, which pancreatitis, when it does get severe, you can get a hemorrhagic pancreatitis, which can be life-threatening. Treatment for symptomatic pancreatitis is to address any life-threatening conditions, and for that, in that given situation, it's going to be volume loss. The patients may be hypotensive, dehydrated, may be in shock, so establishing an IV and giving them some IV crystalloids would be appropriate. Nasogastric tube to evacuate the stomach. It's not something we're going to do pre-hospital, but you may be transporting a patient who's been diagnosed with pancreatitis, who's going to a larger facility for some tertiary care. Obviously, if their blood pressure supports it, giving them some analgesics like morphine or fentanyl for their pain would be appropriate as well. Pancreatic tumors are divided according to cell type. 95% of pancreatic cancers are adenocarcinomas derived from the exocrine cells. And if we remember the pancreas, the exocrine cells are those cells in the pancreas that secrete pancreatic fluid, which is used in the digestion of food. So 95% of pancreatic cancers are caused by those cells. Cyst adenomas, they're benign tumors that are the result of infection and the exocrine cells that cause these cysts. And then neuroendocrine tumors, or neuroendocrine islet cell tumors, are endocrine cells of the pancreas causing those tumors. And if you remember, the endocrine cells would be those cells in the pancreas that secrete insulin and glucagon. Symptoms of pancreatic tumors are much similar to symptoms of pancreatitis. Very dull pain in the upper abdomen radiates to the back. Painless jaundice develops as the tumor obstructs the bile duct. Weak, dizzy, hypoglycemic if it's an endocrine tumor, where it's not allowing the secretion of both insulin and or glucagon. Treatment is supportive. If there are any life-threatening emergencies, certainly treat those. If they're in a great deal of pain, treat the pain. If they're retractable vomiting and lots of nausea, some Zofran certainly would be appropriate, as long as their vital signs support all that, and then transport. Peritoneal membrane inflammation. When the peritoneum, the lining of the abdominal cavity, becomes inflamed, that can be the result of infections, that can be the result of trauma, that can be the results of bowel rupture. So when the hollow organs rupture, they're going to spill their contents into the abdominal cavity, causing an inflammation of the peritoneum, which is called peritonitis, which we also call acute abdomen. Trauma may cause both the rupture of hollow organs, which will spill their contents, and solid organs, which will bleed, and both of those things will irritate the peritoneum. Signs and symptoms of peritonitis: abdominal pain, fever, nausea, vomiting, loss of appetite, rebound tenderness. And again, I've kind of alluded to my dislike of rebound tenderness. However, if that's something your medical director would encourage you to do, then I guess you got to do it. They could be septic with a fever, and septic, we may see presepsis, which is known as SIRS, systemic inflammatory response syndrome, where if they're tachycardic, tachypnic, they've got a fever, and their white count's elevated, that's, if they've got 3 of those 4 things, then they have SIRS, and if not addressed, will become septic. Hypothermia comes in the later stages of sepsis. Fever is going to give you chills. Certainly if a bowel is ruptured or a solid organ is bleeding into the abdomen, it could lead to hypotension. Bowel sounds may be decreased or absent as an ileus forms. Spontaneous bacterial peritonitis occurs in liver cirrhosis. The patient may be asymptomatic. It's the result of portal hypertension. Portal hypertension refers to the backing up of blood when the liver fails into the portal veins, and causing the pressure inside those portal veins to be elevated above what normal would be. That causes a backup of blood into other vessels that do feed into the portal vein. So it causes the bowel wall and the mucosa to swell as a result of this bacterial infection. Symptoms are a worsening hepatic or renal function, underlying liver disease, the presence of septic shock, and for the shock you need lots and lots of IV fluids. Remember that in sepsis the toxins cause a dilation of the container, so your container is twice as big, so it's half as full. And then top that off, the continued release of the toxins may cause an increase in capillary permeability, so the capillaries begin to weep or third space. So you end up losing lots of volume, and so you may have to give these people 3, 4, 5, 6 liters of fluid right off the bat. If their pressure supports it and they're in a lot of pain and they're sick to their stomach, certainly medications for pain and medications for nausea would be appropriate. Gastritis is a inflammation of the gastric mucosa. Chronic gastritis is caused by Helicobacter pylori, and that Helicobacter pylori is a bacteria, which again I think I had mentioned that in many people who had ulcers, the belief was that it had to be related to the amount of acid that they were producing, and by giving them acid reducers, they thought they would cure these ulcers, but that wasn't the case. And then they found out that, well, if you have this certain bacteria in your GI tract, you have a tendency to get gastritis. Acute gastritis is a result of local injury to the gastric mucosa. Could be a viral infection, could be a substance that you ingested that irritates the gastric mucosa. Alcohol, prescription and over-the-counter medications are common causes of gastritis. Chronic alcohol use certainly can be inflammatory to the GI tract and the abdominal tissue. Prescription and over-the-counter medications, particularly aspirin and NSAIDs like ibuprofen, naproxen sodium, those things will cause an inflammation of the inside of the stomach. So here's an example of an acute gastritis. Normally that tissue should be yellow, but you can see that it's got streaks of red, and those streaks of red, those red spots and things on that tissue of the abdomen is an indication of inflammation and swelling. Acute gastritis signs and symptoms: a lot of gas, bloating, indigestion, heartburn, belching, nausea, vomiting. Hemorrhagic gastritis may develop as a result of chronic inflammation, chronic inflammation of the stomach, and in that case they may develop some hematemesis, so they may be vomiting up some blood. The blood may be bright red. If it's significant hemorrhage, it may be coffee ground. If it's just a small amount of hemorrhage, if it's a small amount of hemorrhage, they may develop melena, which is the black tarry stool that you see in patients with gastrointestinal bleeds. And the bleeding may be significant enough to cause hemorrhagic shock. It may not be a sudden hemorrhagic shock with lots of blood loss, but chronic blood loss over time certainly can lead to hemorrhagic shock as well. You're going to get most of the information about whether or not this is gastritis or some other problem by the history. So get a really good thorough history, your sample, your OPQRST. Ask questions about the current pain, their medical history, their medications, their social history. Social history refers to, certainly their alcohol consumption, their smoking, things that they might do in a social environment. Treatment, if the hemorrhage is severe enough to cause shock, then you need to treat the life-threatening conditions, but that would be bleeding inside, bleeding that we can't see. So we're going to, if the pressure's less than 90, we would consider giving them some fluid, but as long as the pressure's over 90 and they've got radial pulses, we're not going to be administering any IV fluids. Rapid transport, position of comfort, if blood pressure will support it, certainly manage their pain and nausea, and continually reassess. Peptic ulcer disease, stomach and small intestine, gastric mucosa defects. They can bleed, they can cause pain, they can cause morbidity and death if they perforate. They're formed when production of hydrochloric acid and pepsin by the gastric mucosa is increased. And the little lesion in the center of this slide is an example of a peptic ulcer that's eroding away the wall of the intestine. Some common causes of peptic ulcer disease include aspirin, NSAIDs like ibuprofen, naproxen sodium, smoking, heavy or prolonged alcohol consumption, H. pylori, an imbalance between stomach acid production, the inability of gastric mucosa to prevent acid damage, and the Zollinger-Ellison syndrome, and that's where you have gastrin-secreting tumors that secrete lots of gastrin, which is the gastric acid. Peptic ulcer disease occurs in the stomach or the first part of the duodenum. It's a burning, gnawing pain in the epigastric region, or it may be a vague or cramping pain. Complications of peptic ulcer disease include perforation, inflammation and swelling to create an acute bowel obstruction, hemorrhage if it's significant enough, bleeding, hemorrhage, same thing. I don't know why they list that twice. The patient may be pale, tachycardic, hypotensive, and they may throw up bright red blood or red blood. Frank hemorrhage refers to visible blood in the vomit. The history is going to be key. Focus on the symptoms as well as how they describe the pain and how the relationship of pain is to the food they eat. If they've ever been previously diagnosed with peptic ulcers, do they take any of those medications? Are they heavy alcohol users? Those sort of things that would indicate that perhaps they have peptic ulcer disease. You're going to do a primary survey like any patient when you do your physical exam, and making sure that there's no life threats. If they've got bright red blood or visible blood in their emesis, it may be significant enough to cause shock, so certainly measuring vital signs and looking for that, and beginning shock resuscitation would be important. They may tell you about these black, sticky, tarry stools that are very foul, and you certainly may smell them if they've had one prior to your arrival. If you've got signs and symptoms of shock, certainly that requires transport to a hospital. And if they're stable, it says complete an abdominal exam. And again, so I guess they're saying here that if they're unstable, don't bother pushing on the abdomen because it isn't going to change anything that you do. But if they're stable, go ahead and push on their abdomen and just make them hurt more. I don't quite get that. Peptic ulcer disease, there is no treatment available. People take antacids, they take H2 blockers for the pain. They may go on a course of 14-day course of Prilosec or some other H2 blocker, and lay off the alcohol and watch what they eat, and oftentimes they may heal. With upper and lower GI bleeding, this would be bleeding above the ligament of Treats, caustic ingestion, Mallory-Weiss tears, esophageal varices, gastritis, and peptic ulcers. It's predominant in men more so than women, and it might have a lot to do with their alcohol consumption, their diets, that sort of stuff. When you have upper GI bleeds, there'll be abdominal pain. It'll be sharp and burning in the epigastric region, may radiate to the back. They may be throwing up some blood. It may be coffee ground, or there may be some frank blood, depending on how serious the bleeding is. And if it's a very slow bleed, the development of the melena or the black tarry stools for upper GI bleeds. Lower GI bleeds are GI bleeds below the ligament of Treats. Causes are diverticulosis, tumors, polyps, hemorrhoids, autoimmune diseases like Crohn's and ulcerative colitis, anal fissures, and these lower GI bleeds from these causes are predominantly in females. Something to keep in mind with lower GI bleeds is bright red blood coming from the rectum. Hematochezia refers or implies to a very large, more rapid blood loss. You have to rule out other sources of hemorrhage, like hemorrhoids. Can also be a hemorrhage. Ruptured polyp can be a cause of hemorrhage in the lower GI tract as well. Get a good medical history on these patients with either upper or lower GI bleeds. Do they have a history of GI bleeds? What is their social history? Do they smoke? Do they drink a lot? That sort of stuff. Fatigue, shortness of breath may go hand in hand with anemia, which may go hand in hand with very slow and low GI bleeds. Have they had any vomiting? And if so, was there any blood in their vomit? Was it coffee ground emesis? Do they have any black tarry stools, which is the melena, or hematochezia, which is the bright red blood coming from the rectum? For lower GI bleeds, if the bleed is very mild, there shouldn't be any signs of shock, and supportive treatment would be okay. When we're talking about massive lower GI bleeds, there may be blood running out of the rectum when you get there. It may be frank and very visible in nature, and you'll essentially have to treat for shock. Gastroenteritis is an inflammation of the stomach lining and the intestines. It causes disruption in the normal functioning of the mucosal lining. Symptoms of gastroenteritis are cramping, abdominal pain, nausea, vomiting, fever, anorexia, malaise, just feeling really weak and punk, headache, watery diarrhea. Many of these symptoms are identical to what you see in gastritis. Many of these symptoms are identical to what you see in peptic ulcer disease. So it's oftentimes very difficult to determine what type of bowel disorder a person has. Gastroenteritis is caused by a virus. It's typically passed from person to person after eating contaminated food. So that might be your key in the history, is that a person maybe have consumed some food at a buffet, which is typically where these viruses love to hang out, like the Norwalk virus, the norovirus, the adenovirus, the astrovirus, and the rotavirus. They're all viruses that certainly can cause the bloody diarrhea, the abdominal cramping, and that sort of stuff if consumed or passed from person to person eating contaminated food. Gastroenteritis is often transmitted through the fecal-oral route. Fecal-oral meaning the food preparer who goes to the bathroom and doesn't wash their hands when they're done. Poorly cooked meat is another route of transmitting these viruses. Poorly refrigerated food, contaminated food may come in with parasites. Also, gastroenteritis could be the result of wheat intolerances. And a more severe form of that certainly is a celiac disease, where there's an intolerance to all gluten. Lactose intolerance can cause gastroenteritis. Allergies can cause gastroenteritis. Autoimmune conditions like Crohn's and ulcerative colitis, irritable bowel syndrome, those sort of things. Medications, aspirin, NSAIDs like ibuprofen and naproxen sodium, radiation therapy, and then chemical toxins. Chronic causes of gastroenteritis include infection, long-term medication use, inflammatory conditions like celiac disease, like Crohn's, like ulcerative colitis, and toxins. To determine whether somebody has gastroenteritis, you're going to get that from the history. You're going to use your OPKRST sample in order to determine what's going on with the patient. Has it been possible food poisoning? Were they camping and hiking outdoors? Did they travel to a foreign country? Were they swimming in potentially infected water? Do they have any other previous medical conditions, or have they ever had this sort of condition before? Have they ever been diagnosed with gastroenteritis before? Physical exam, you get a detailed exam of the abdomen. You're going to have increased bowel sounds on auscultation because the bowels are going to be hyperactive. Especially if there's any liquid or watery diarrhea, they're going to be really hyperactive. Mild tenderness on palpation in all four quadrants because your intestines transverse all four quadrants. You can check the skin for tenting to indicate whether or not they're dehydrated. If they've had significant diarrhea and not much intake because they haven't been feeling good, they may be mildly dehydrated. Muscle spasms would occur from the loss of electrolytes like potassium. So giving them lactated ringers, giving them normal saline may be appropriate in this case. Treatment for gastroenteritis is IV access fluids. If they've got a lot of nausea, some Zofran. If they've got a lot of pain, certainly pain meds are appropriate as well. Bowel obstruction, you can have large or small bowel lumen blocked by some sort of obstruction. Large bowel obstructions are usually caused by malignant diseases like cancer. The bowel contents cannot flow forward. It disrupts the normal function of the digestive system, and the person may develop an ileus. An ileus is when the bowel loses normal peristaltic movement, so peristalsis stops. And when peristalsis stops, things don't move through the system, and they have a tendency to back up. You can get an ileus when you're ill. You can get an ileus after abdominal surgery. You can get an ileus after recent surgery, and you can get an ileus on certain medications, particularly your opioid medications. Anything with codeine, morphine, any of those things cause a sudden decrease in peristalsis. Bowel obstruction results from complete mechanical obstruction of the intestine, as well as in the case of adhesions where the bowel walls stick together. Hernia, if the bowel herniates out into a compartment and becomes twisted. Polyps, which can obstruct the inside lumen of the bowel. Tumors, foreign bodies, impacted stool. Intussusceptions is when the bowel telescopes within itself. Seen more in children than others, but when it does occur, it leads to a bowel obstruction. Or a volvulus, which is a twisting of the bowel, where it gets twisted. And that not only obstructs the bowel, but also decreases blood supply distal to that volvulus. Signs and symptoms of obstruction include nausea and vomiting, because everything's backing up in the system. They may have abdominal pain. They may tell you they haven't had a bowel movement in days. Or they may have diarrhea, because the only thing that is getting through that obstruction is really watery liquid stuff. They may not be able to pass gas, and their abdomen may be distended. They may have pain that they describe as crampy or colicky. Get a good past medical history. Ask them if they've had any other previous bowel obstructions. Have they had any abdominal surgery or cancers or radiation therapy lately? Any chemotherapy? Examine the abdomen for the presence of a hernia. Do they have any abdominal illness? Do they have any nausea or vomiting? And what are their bowel habits? Are they able to have a bowel movement regularly, or do they get constipated at times, or do they normally have 5 or 6 loose stools a day? Physical exam, you're going to do a primary survey, and then once there are no immediate life threats, you're going to do a thorough abdominal exam. Put them in a position of comfort, give them IV access, replace fluids if they've had lots of vomiting. Look for dehydration, and again, if they are, give them fluids. Avoid food and water by mouth if the bowel is obstructed. We just don't want to put any more in there until the obstruction is open. They may require an NG tube, and the NG tube is going to be used to remove the normal fluids that are produced by the stomach, as well as anything that may be in the stomach when you get them to the hospital. If they're in a lot of pain or discomfort with this bowel obstruction, which they may be, there's nothing wrong with giving them something for pain like morphine or fentanyl, and then some Zofran for significant nausea, and then transport them to a facility where they can be diagnosed. Appendicitis is an inflammation of the small tubular structure arising off the colon near the cecum. Fecalith obstruction can occur where you can actually get material in the appendix, which is like fecal matter. The appendix becomes highly distended, inflamed, and gangrenous, and then if it ruptures, those toxins and all those poisons are spilled into the abdomen, causing a peritonitis. Symptoms of appendicitis include fever and nausea, abdominal pain, and the pain is usually dull in the preumbilical area, so around the belly button is where their pain is. It may radiate to their right lower quadrant or their right lower back. Certainly if you suspect appendicitis, ask them if they've ever had their appendix out. What's their appetite been like? Where's their pain located? How did it come on? Do they got a fever with it? On physical exam, it's not likely they're going to have a normal abdominal exam, but you want to do an exam of the abdomen to determine where the pain is located. And if they've got pain with movement of the pelvis or hips, that may be a good sign it's the appendix. Rovsing's sign is pain in the right side of the abdomen in response to pressure on the left. That's a classic sign seen with appendicitis. The appendix location varies, but typically we're going to look for it at McBurney's point. And McBurney's point is 2/3 of the way from the umbilicus to the anterior superior iliac spine. So you find the anterior superior iliac spine and you find the belly button, and 2/3 away down that line from the belly button towards the ACES, that's the McBurney's point, and that's typically where you can find in that general area the appendix. Treatment is IV access, fluids for the nausea and vomiting. Avoid anything by mouth. Again, if they're in severe pain, we can give them medications for pain and should do so. If they're nauseated, give them something like Zofran for their nausea, and then transport them in the position of comfort. Ulcerative colitis is an inflammation of the large bowel. Ulcers from a mucosal surface of the intestine. It affects the colon and most of the rectum. It occurs when the immune system overreacts to a viral or bacterial insult. So in a person who suffers from ulcerative colitis, when they do have a higher than normal bacterial count in their colon, or a higher than normal viral count in their colon, it can become really inflamed and lead to ulcerations. So here's an example of an ulcerated colon. Particularly there on the right-hand side, you can see all the discoloration of the intestine compared to the left-hand side. All that discoloration is inflammation, and if left untreated, certainly can lead to a variety of problems, to include dehydration, electrolyte imbalance, and ulceration or perforation of the colon. Symptoms of ulcerative colitis: diarrhea, abdominal cramping, bloody purulent stools, fatigue, very weak, may have some significant weight loss, appetite loss, and they may know they have the ulcerative colitis, but maybe if they have an increased history of periods of painful diarrhea, maybe even some blood in their diarrhea, reoccurrent fatigue, reoccurrent abdominal discomfort, that might be a clue they have some ulcerative colitis. You do a thorough exam of the abdomen, understanding that ulcerative colitis could look like any of these things. Ulcerative colitis could appear like appendicitis does, like a bowel obstruction does, like gastroenteritis does. So when we have significant pain in the abdomen, we're just not likely to know what's causing it. We can do some exams and some diagnostics and might have an idea or a potential differential, but there are just so many things that it could be, and they all present very similar, that it's difficult to make a diagnosis. So I think what our responsibility is in these particular bowel disorders is to see if they have any sort of abdominal catastrophe going on. Are they hypotensive? Are they in shock? And if so, treat that. For the treatment of ulcerative colitis, it's supportive. IV fluids if they're dehydrated from the diarrhea. And again, if they're nauseated and vomiting, you can give them Zofran. If they're in a lot of pain, you can give them morphine or fentanyl. And then transport them in a position that's comfortable. Crohn's disease is very similar to ulcerative colitis, but it affects mostly the small intestine. It can infect some of the large intestine, but it's mostly found up in the small intestine. Crohn's disease has a tendency to be genetic, so chances are if you have Crohn's disease, somebody in your family had it as well. There's a significant swelling of the small intestine. It can lead to ulcerations through all layers of the bowel. Scar tissue can form from the significant swelling of this disease when it flares up, leading to things like bowel obstruction. Signs and symptoms: nausea, vomiting, severe diarrhea, abdominal pain and cramping, weight loss, appetite loss, poor skin turgor, arthritis. They may also have arthritis because strangely enough, people with Crohn's have a tendency to have other autoimmune diseases like arthritis. They may also have gallbladder disease, inflammatory eye conditions, ulcerations of the nose and mouth, and may be prone to kidney stones. With Crohn's disease, get a really good history about their abdominal cramping. Is it right upper quadrant pain, kidney stones, arthritis? Do they have any bladder or vaginal problems? Do they have a fistula with pus or stool leaking from an ulcer in the skin? You can see that with Crohn's disease as well. Do a head-to-toe exam, a thorough exam of the abdomen. If they have a peritonitis, in other words, a rigid, distended abdomen, board-like, lots of pain, they may have ruptured their bowel. They may have abdominal distension, rebound tenderness, fever, and certainly if there's been any sort of rupture, they can develop severe sepsis. So Crohn's disease could be life-threatening. Do a rapid assessment, treat life-threatening conditions, manage their ABCs, gain IV access, and again, medications for pain, medications for nausea and vomiting, and rapid transport. Diverticulosis and diverticulitis. Diverticulosis and diverticulitis are small sacs or outpouches that form along the bowel wall. They're often seen in fiber-deficient diets, and diverticulosis is multiple diverticula, and they develop from the bowel wall stretching. They may be asymptomatic as long as they don't get plugged with stuff. Person may have painless bloody stools with diverticulitis, may have irregular bowel movements, soft stools, frequent movements, those sort of things. And in that picture, you can see these holes. Those holes in the intestinal wall are little outpouches that are called diverticuli. With diverticulitis, the diverticuli become inflamed and infected as stuff gets stuck in those little pouches. The digested food is trapped. It causes an infection, fever, shaking, nausea, vomiting, abdominal pain, diarrhea. And here you can see diverticuli where things are stuck in those diverticuli. Diverticulosis and diverticulitis, they're going to have nausea, vomiting, fever, chills, pain. Oftentimes they know they have diverticulosis, so compare this pain to their previous abdominal complaints. Do a good physical exam, sample history, OPQRST, try to figure out what's going on. Exam not only the abdomen but the pelvis as well. Treatment is supportive. If they're dehydrated, IV access, give them some fluids. If they're having a lot of pain, give them pain medication. If they're having a lot of nausea, then Zofran. Hemorrhoids are swollen venous tissues originating from the anal area. They can be internal or external. Increased pressure or straining during defecation causes them to be external. Sitting for long periods of time certainly increases the risk of hemorrhoids. Pregnancy increases the risk of hemorrhoids. Signs and symptoms include itching, pain, and burning, rectal bleeding, bleeding that drips into the toilet after defecation, or bleeding that may show up once on the first wipe of the toilet paper. Get a history of their bowel habits. Do they have a history of hemorrhoids? Did it come on as they strain themselves? Is there bleeding that stains the toilet tissue? A large bloody stool would be treated more like a GI bleed. Hemorrhoids can bleed a lot, but typically they don't. Typically because of the constriction of the anus itself, the hemorrhoids are they typically are compressed and don't have a chance to bleed a lot unless they're external. Do a good physical exam. Treatment is supportive for hemorrhoids. We don't carry preparation H, but certainly something to relieve the itching and the burning and the discomfort is what they're going to get. Gastrointestinal illness. Getting an acute history is important. Gastrointestinal illnesses can be life-threatening. They can lead to sepsis. So get a thorough history and physical exam. Ask open-ended questions. If there's any sort of pain, using the OPQRST as a mechanism to assess for pain is important. If they've got nausea, vomiting, and diarrhea, certainly ask them about their diarrhea. How frequently is it occurring? What's its consistency? What's its color? Is there any noticeable blood? Treatment for these gastrointestinal illnesses that we've been talking about. Address any immediate life threats that may occur. They may be in shock as a result of large blood loss, so you have to assess them quickly and transport them quickly. As long as they've got radial pulses, there's no reason to establish an IV, or no reason to necessarily run fluids in, but certainly you can establish an IV TKO until there's a need for fluid resuscitation. All right, with that, that pretty much wraps up the Chapter 26 on abdominal conditions, and I'll be talking to you soon, I believe, about renal stuff. And then when we get through all the medical conditions, we'll look at May, I believe, coming down and doing an AMLS course, Advanced Medical Life Support course, which I think you'll all enjoy. So have a good day, and I'll talk to you soon. Bye now.